Well, let's get right to it, because this is going back to the outset of this discussion, Belinda. I learned about you. I don't even know how. I think I was like literally just watching stuff on YouTube and somehow saw a clip. It's probably many years old, from local news in Australia, highlighting you talking about the Lift More study. And there's just something, like, if you look at the things that I can get sucked into on YouTube, it's car videos, F1 videos. Like there's this world that just sucks me in. But I'll tell you another one of the things that sucks me in: videos of elderly people lifting weights. I can go down that rabbit hole like it's my I mean, it's ridiculous. You show me a 90-year-old woman deadlifting, and like that, I could watch that for days. So that it must be that the algorithm knows that, and it served you up to me. So, so let's talk about the Lift More study.
So I suppose around about 2013, I got to a point in my research career where I looked around and thought, okay, the guidelines for the exercise guidelines for osteoporosis are: get your kids jumping and running and playing as much sport as possible. Keep doing that for as long as you can. But then when you get osteoporosis, stop doing all that and just prevent falls so you don't break. And so are we done? Is this the best we can do? This is lame. All my animal research experience had told me that even with very low bone mass animals, if you load them, they can grow bone. The only reason we hadn't been doing that in research is because we were terrified of hurting someone. And so it seemed to me like we hadn't really tried. And at the risk of hurting somebody, we decided to do it. So we had 3 physiotherapists on that trial, including the Ph.D. student who ran it, Steve Watson. We decided to do a brief, because bone doesn't need a lot of loading. You don't need to run a marathon. You just need to do one sprint to get those bone cells stimulated. So we had twice a week, 30 minutes, 4 exercises, and we wanted them lifting heavy. So it was 85% 1RM. We used compound movements because we wanted them, this needed to be an efficient project. We wanted to involve as much muscle as possible. It needed to be weight bearing. And we wanted something that would transfer to really useful daily activities. So clearly a squat and a deadlift was going to be fundamental. These are fabulous compound movements that they tick all those boxes. And these are not on machines. This is with free weights, because you want to engage as much of those other systems and capacities as possible. We're trying to improve balance because we're trying to stop people falling. So away we went. It needed to be, ideally we wanted it to be 12 months, because you do need a fair amount of time to be able to detect change on DEXA, because DEXA, ionizing radiation, picks up mineral. So you can't just measure new bone, which would be the osteoid, unmineralized. You need a full period of time to allow for a full remodeling cycle and mineralized bone. Because it was a PhD project, we couldn't afford a full year for every person, so we just made it an 8-month intervention, which I was confident would be enough to detect a change. We did really comprehensive bone and functional measures at baseline. We recruited about 100 people, randomly allocated them to this high-intensity resistance and impact training, and because in research you have to, exercise research is really hard to blind to your participants, and blinding is so important in clinical trials. So we had to not tell our participants which was the intervention that we thought was going to be effective. We just said, if you got randomized to this low intensity home program, we were trying to see whether that worked too. Of course, we knew that that was not going to work, because we've got years of experience to know that that is not going to improve bone. But we gave them things like walking, stretching, some body weight lunges and toe raises, and things that would potentially improve their balance. So we weren't completely ripping them off. So then we had 8 months of this intervention. It was
And
supervised
sorry,
twice.
once again, Belinda, you said the treatment group was 20 minutes 3 times a week?
No, 30 minutes 2 times a week.
Got it.
Yeah. Maximum group size was 8, and we recruited postmenopausal women. So we were looking for people, we advertised for over 60, but I think we did recruit one person who was 58 because she had been through menopause when she was young. And they just needed to be well clear of menopause. We didn't want to be fighting that withdrawal of estrogen phase. And they needed to have low bone mass. So they needed to be at least a T-score of -1 at either the spine or the hip. So away we went. And I have to say, we were looking through our fingers for a little bit, and we were so incredibly conservative to begin with and just being very careful that we weren't hurting anybody. It became abundantly clear very quickly that we weren't hurting anybody. In fact, we were making people feel a lot better.
Let me just ask you about that, because again, the video, which we'll link to in the show notes, was, even though it was just a local news segment, was just really inspiring. I think there were women there that were at some point basically able to pick up their body weight. I mean, am I remembering that correctly? Like literally these women were deadlifting their body weight.
Yeah.
How did you even train them to do this? So these women show up to this study, and they're probably told it's an exercise study, so they think, great, I'll be doing pool jogging or something, and then you drag them into a weight room with Olympic bars. How did you even go about getting them to do this safely? How much resistance was there on their part to the fear of weightlifting? I assume prior weightlifting experience was not an inclusion criteria.
No, they could have had it, but they couldn't have been doing anything in the past 12 months because bone is a use it or lose it tissue. So they needed to not be already doing this. We described it as, we told them what the basic exercises were. So these had to be people who were willing to do this. We never throw somebody straight into lifting something extremely heavy, and certainly nobody would have expected that we would end up with people lifting their body weight, certainly, least of all us. We just did it very systematically. You start with a broomstick and you make sure that people's technique is good. And I have to tell you, we had people with fractures. So they had existing kyphosis. And what a kyphotic curvature looks like in a deadlift position. This is not a pretty thing. But as long as they had an extensor moment, it was okay. We don't want people flexing and lifting weight because then we're putting them at risk of fracture. But it's all in the coaching. And this is the reason why it's so important that the person who is coaching somebody with osteoporosis knows what they're doing. They can't just be a strength and conditioning coach, although that really helps. They have to have an understanding they have to have some clinical training. So, because people come to you in a clinic with not just osteoporosis, but pelvic floor dysfunction, frozen shoulder, spondylolysis, vertigo, just every knee-OA. You've got to be able to manage that. Many of those conditions were actually screened out of the Lift More study because it was the first time we were doing it. And we didn't want to have to manage all of that. But I just put it out there because it's something I want to remember to talk about. So it was all about just systematically training them in the technique and then gradually increasing the load. And a lot of people think of older people, and particularly older women, and particularly postmenopausal women who, the assumption is they go completely loopy through menopause, which is not true. They think about old people as completely incapable of doing stuff and incapable of learning. But old people are you and me who just kept living longer. We have the capacity to learn, and older people are perfectly capable of learning how to do a deadlift and a squat. It might be pretty ugly to start with, but they get better. And as they get stronger, they get even better. So
I just love it so much. I cannot for people listening and not watching right now, just the grin on my face listening to you talk about this, it just warms my heart. And again, I just agree with all of that. I think that one of the saddest sort of, I think, misconceptions people have is that once they get to a certain age, it's too late. And they sort of accept their fate. And, oh, I have this kyphotic spine, and, oh, my bones are too brittle, and I guess I'm just going to spend the next decade of my life doing nothing. And studies like this demonstrate that that's not the case. And so, I'm looking for some of the other kind of soft stuff as you think about the evolution of this study. I mean, what else did you notice in the subjects? What did they tell you? How did this translate into the rest of their lives? Because obviously you as an investigator are looking for something very specific, right? You want to probably understand how much muscle mass they put on, what their bone density did, how much their T-scores changed. But were there other things that you learned about these women as the study went on that spoke to their quality of life?
Oh, yeah, undoubtedly. And for them, that was the most important thing. And that is what made me want to open the clinic. This is a quality of life issue. It turns out this is not a bone issue. I'm a bonehead. I care about what their BMD scores did. But the reality is, comments like, oh my God, Belinda, I can see my shoulders in the mirror again, because their posture changed. The fact that we had, when you do a clinical trial, you measure height and weight as the standard baseline, how to describe your population. Who knew that we would actually be citing height as an outcome? Because the control group shrank, whereas the intervention group grew a little. Of course, they didn't grow, but their posture improved to the extent that they were taller at the end of the study. And the difference between groups was significant. It was only 0.5 centimeter, but hey, wouldn't you prefer
That's
to
in
maintain
8 months. I mean,
yeah. And so those, if you like, soft outcomes, people saying, my husband is hiking the Kokoda Trail, and I just thought I was going to be cheerleading. I can go with him now. I've got this incredible strength. I've basically got my life back. I can get into the garden, and I can push the wheelbarrow full of potting mix around now, and I don't feel like I'm going to break. And I can lift my grandchild again. I can get my own shopping out of the car. It's all about independence, quality of life. We measure quality of life as well, and at the clinic, it's pretty obvious that is something that is improving.
So, what did you find after 8 months with respect to muscle mass, bone density, and the other sort of clinical metrics?
Yeah, so we ended up with a net benefit of a bit over 4% at the spine. That equated to about 3% improvement at the spine in BMD and about 1.5 or 1 and a bit loss in controls. I would say that this program definitely has the biggest effect at the spine, which is, that is a good thing, because one of the places that fractures most frequently. At the hip, it was a real head scratcher. When I first looked at the results, we had something like a 0.6% improvement at the femoral neck. And I'm thinking, these women deadlifting and squatting 70 kilos, how can that be? We ended up with a significant difference because the controls lost 2.5%. So there was a net benefit, but I couldn't figure it out. Luckily, I have some 3D hip software, which allows me to reanalyze my 2D BMD data from DEXA and look at the changes in geometry. From that, you could see things like cross-sectional area of the femoral neck, cortical thickness, and so on. When you look at cortical thickness of the total femoral neck, there was a 13% net benefit in the intervention group. And if you looked specifically at the lateral femoral neck cortex, there was a 27% improvement. So it turns out that if you were just looking at BMD from DEXA, it would look like, this kind of lifting only has a maintenance effect at the hip. But actually what's happening is it's changing the geometry. It's making it stronger by making the cortex, that cortical bone, thicker and more resistant to bending. So that was another of those fantastic moments where I had only just got this software and it was just in time to show this really novel outcome.
I think that's such an important point, by the way. And given that most of us clinicians don't have access to that, can we, in your opinion, rely on the stabilization of the Z-score or the improvement of the Z-score, the stabilization of the T-score as a win if we're in that situation? So we have that patient who comes in at a -2, you get them on a strength training program, they're putting on muscle mass, the Z-score gets better, but the T-score does not. You still say, look, you're probably winning, even though you don't have the radiographic tool to document the cortical bone thickening?
Yeah, if you can maintain bone mass at the hip, bone mineral density, yes, that is absolutely a win. And, don't get me wrong, there were some people who probably the largest gain we had at the hip in the Liftmore study was about 6%. So there were some people who improved BMD. But, on average, it's something that you don't always see. And
the important thing I think for people to understand here is even if going on this type of a training program at best maintained you, let's assume even the cortical thickening was maintained, there's two important points to consider. The controls are having the floor dropped from underneath them. So that gap between what you would be doing and what you're doing is widening, even if you're not getting better. So the fact that you're even getting better slightly is mind-boggling. But even if you don't, the gap between where you are and where you would be is enormous. The second point is your fall risk is going down dramatically because you're putting on muscle mass. And to the very important point you made, you're using these free weights and you're improving your balance. So you have more muscle, more balance, more motor control. The likelihood of falling to get in the position that you're going to break a bone is going down so much. So when you add to the fact that, and by the way, cortical bone is increasing by 13%, like this is just a win across the board.
And show me a bone drug that does that. So it's if you look at our functional outcomes, we had back extensor strength, leg extensor strength, and then we had tandem walk, timed up and go, sit to stand, vertical jump, and we also measured kyphosis. All of those things improved, but especially lower extremity strength and back extensor strength. Now, people think, back extensor strength, yes, it's just making them stand up straighter. But it's not there's no just about it. If somebody has kyphosis and their posture is such that their vision is angled downwards, they've lost that peripheral vision for, say, when they're walking to their car at the shopping center, which is not their comfortable environment. So, perhaps a little kid runs out in front of them and they haven't seen them coming. And that's when a fall can happen on a hard supermarket floor. Walking outside their own home and the neighbor's dog runs out, they don't see it coming, they get a fright and they'll fall. So posture is actually really, really important to fall risk and risk of fracture, because we know pretty much half the time you fall, you're going to fracture.
I would add something even more to that, which is, we have a couple of folks in our practice who are really forward thinking in their understanding of the role of vision in brain health. And we know this is true with auditory stimuli as well, right? So we know that, hearing loss is a risk for dementia because it's reducing sensory input to the brain. And, we would argue that you see the same thing with a reduction of visual input. So a reduction of visual input is a reduction of cortical stimulation, cortical meaning brain, cortical, and that's also increasing problems. So in addition to everything you said, which is this increased risk of falling as vision is getting narrower, you're also reducing kind of brain input, and I think you run the risk of also exacerbated or accelerated degeneration of the brain. So yeah, I agree with you completely. It's not that you just reversed kyphosis. That's a really big deal to get somebody looking up and forward. Yeah, it's just, I mean, the other things that I'm sure you saw were improvement in grip strength. So there's another benefit, because you can't deadlift without grip strength. So if a woman's picking 70 kilos off the ground, think of how strong her hands are, and think of the implication of that on mitigating fall risk. You think about that person walking down a flight of stairs. Now imagine the grip they have on the handrail as they confidently walk down the steps. And you think of the devastating injuries that people can have of any age, but certainly older people, when they can't hold onto a handrail and then they don't have the leg strength to stop themselves going downstairs. I mean, again, just to reiterate this point that we can't make enough, which is, yes, there are some really interesting and exciting drugs on the horizon for the management of this. Yes, pharmacology and endocrinology play a very important role in managing these things. I would argue estrogen more than any other drug out there, but none of these things compare or should ever be thought of as a substitute for what you're describing.
No, that's right. I sort of briefly mentioned the tandem walk and sit to stand and timed up and go and vertical jump, and all of those things are risk factors or predictive of your risk of falling. So yeah, we do know that improving those things reduce your risk of falling. You're quite right about grip strength. I do as much of this lifting as I can, but I'm frequently, I've just been to Europe for a month, I've been to the US for a month, and my lifting falls away. So I come back to the gym and go to lift again. And whereas my muscles, my major lifting muscles may be okay, but I end up on my last set, I am just holding onto that bar with my fingertips because my grip strength goes. So it is absolutely part and parcel. This is why these Olympic lifts are so incredibly helpful, because they are compound movements using virtually every muscle in your body, including if you're frowning.